Hi everybody and welcome to the Kidney Coach YouTube channel. I am naturopath Fiona Chin, co-founder of Kidney Coach and Kaigenesis, a range of supplements designed for people diagnosed with chronic kidney disease, whether you want to raise your EGFR and lower your lower your creatinine. We have supplements for you. And I'm joined again today by one of our regular guests, the beautiful, the wonderful Therese L'Seow. Therese is a consultant pharmacist, health strategist, and wellness researcher. She specialises in bridging the gap between traditional medicine and functional health strategies. She's got a keen focus on chronic conditions like CKD, metabolic health syndrome, diabetes, blood pressure, and she's amazing at providing practical science-based solutions that empower individuals to take control of their health. She also is the host of the Enlightened Pharmacist podcast, which is on a mission to help 10,000 individuals reclaim their health through personalised care. So what I love mostly about Therese is, and she's been working with a couple of my patients, is just how collaborative you are and just how much you make my life easier, because I'm not an expert on pharmaceuticals. And, you know, like when I've got patients coming to me, which can happen with older people with CKD, and, you know, sometimes patients are on 20 plus medications and, you know, there's a particular patient I'm thinking of. And I now have Therese in my toolbox, which means I refer patients off to her. She will do a review process. She comes back to me and I'm like, CKD's tanking. I think it might be due to medications. And 9 times out of 10 she goes, yes. And then what's amazing is that she then works with the client one-on-one to help maybe take out medications and put in lifestyle advice that might just be as effective, and we can manage things and do all of that. So I just feel like, as part of my team for really chronic health conditions, which is what I do, you've become an invaluable member. So thank you for that. I don't know what I did without you before that. But today we're talking about all things antibiotics, and we get asked a lot. You know, we've talked about the triple whammy and lithium, but people often want to know what antibiotics are safe in chronic kidney disease, especially if people are prone to chronic UTI infections or kidney infections where they might actually need to take an antibiotic but aren't sure which ones are more likely to cause kidney damage. So that is what we're talking about today, Therese. Thank you so much for joining me and being your wonderful, fabulous, amazing self.
It's a pleasure, and the feeling's mutual. I love working in your team. It's so inspiring, doing chronic disease prevention. Fiona, I remember working in hospital, calculating drug dosages for antibiotics, especially those with what we call a narrow window, like a narrow therapeutic index, like gentamicin, when there is a fine line between benefit and harm. It is fascinating, but it's also sobering, because sometimes the science is catching up. And we know that certain mitochondrial DNA mutations are at much higher risk of antibiotic-induced deafness. And we'll talk about the different adverse effects and why is this happening and the mechanisms, etc. But it really has to do with the dose, the clearance, the duration of use, the type of antibiotic, the type of infection, as well as the host environment, whether they're nutrient deficient, whether they're actually immunocompromised. So there's so many balls to juggle in the air. So perhaps it might be a good idea to just break down how antibiotics work.
Yes, do that.
So some rely on peak concentrations, so guns are blazing. Others require a constant exposure over a period of time. It's a slow and steady type of antibiotics. So our individual makeup matters. So somebody with low magnesium, or they have that mitochondrial DNA mutation, they be more vulnerable to hearing loss or kidney damage. So in Australia, we use the Australian Medicines Handbook. And as a pharmacist who wrote a book called The Drug-Nutrient Interaction, his name is Joseph Folate, somewhere in Pennsylvania. And he reminds us to always match the antibiotic, the mechanism to the situation and the patient's context. And if we're actually treating a viral infection with antibiotics, that's also just missing the mark. So when we talk about antibiotics, it only works for bacterial infections. And sometimes these infections that our patients have, it could be a secondary viral infection, and that's when it's not going to make any difference. And it might just increase the pool of resistance. So in summary, antibiotics, they work either on a concentration dependent manner, the all guns are blazing cowboy, or the slow and steady Bill, having a certain concentration for a set period of time. They do work differently. There's so many different antibiotics. So we really want to, again, match it to the type of infection. So one of the key things is understanding how the pathogens work and making sure, whether we want to go for an all guns blazing sort of like strategy or just do a slow and steady state sort of thing. And my concern is like the pathogens over millions of years, they've smartened up. So there's lots of pathogen evasion strategies. So suggesting that drug resistance on the rise, and then we get recurrent infections. And then the understanding of biofilms is emerging, where pathogens build a force field against our innate immune response. So our innate immune response, they are soldiers and they kill, digest, and break down all these bacteria that get into our body. So I think it's a tricky conversation, but luckily in Australia, they have got an antibiotic stewardship program in all health organizations. What we're trying to do is do it in a way that's smart, reduces resistance, but also effectively controls infection. So luckily in Australia, all health organizations, they need to actually meet the minimum standards.
Interesting, because and again, I don't know whether this is your experience, but if I have patients that go to the general GP, they might have a cough or a cold, and I'm thinking viral, RSV is going around at the moment. We've had a really big outbreak of influenza A and B going around, so viral, but they're on antibiotics, which doesn't meet the criteria.
Yes.
And I don't feel like, and I don't know, but I don't feel like general prescribers take that nuance that you've just spoken about to the individuals, whether people just haven't caught up on the latest research, they're not going to continuous education. And of course, doctors are slammed during winter, so this isn't me having a dig, because I get it. They're slammed. People are really sick, especially viral infections really do make us unwell. And people often sit and say, we just want some antibiotics. And yeah, so I feel like that beautiful care that you spoke about and how it should be looked at isn't generally translated into what most of my patients experience. Can you speak to that a little bit? Because I think most people will be like, 100%. That is just not what's happening.
So in mainstream medicine, we do 15 minutes consults, and how much time it would take to actually explain to the patients, this is something, an incentive called like the delayed prescription, where the prescriber provides like a delayed prescription that they don't actually get filled until they may be sure that, if they have a fever or some sort of sign and symptom, that they might actually just fill it up. So because we are practicing 15-minute medicine, this is not even happening because of the amount of time that it would take to actually educate and raise awareness of drug resistance. The legislation is there. Like we have the Prevention and Controlling Infection Standard, which mandates that all health service organizations, they run robust antimicrobial stewardship programs, because conditions like otitis media in kids, like ear infections or infection in the sinuses, they frequently resolve spontaneously. So over the last decade, I've been working at the National Prescribing Service, where we actually provide 30, 45 minutes, so like bite-sized information of the latest and the greatest. We've done a whole section on antibiotics as well. And there are like these bodies which are supposed to actually help support like our prescribers to use the most narrow spectrum antibiotics, the narrowest window, so that it doesn't kill more unnecessary bugs, the cheapest effective agents. And we reserve like the broad spectrum, the ones that actually have the biggest arsenal, like vancomycin, rifampicin, extended spectrum, cephalosporins, when all else fails. But the key thing is about the partnership with the patients on why and when to use antibiotics. That should be the heart of credible, trusted care. But because of 15-minute medicine, first, you spend the time assessing the patient, doing the diagnosis, so easy to reach for a prescription pad. So I think it's, I'm not surprised that it's much easier to fill a script. Not being a prescriber myself, I provide like resources and support in terms of, and there's guidelines as well in terms of which ones to use, when you need to do a specimen or a culture, susceptibility testing, because it's just going to be, if you use a weak or a non-specific sort of antibiotic, it's not going to work, and the patients in the end, they're going to get more frustrated and upset, and probably make the whole trust relationship just go haywire as well. So I don't know. I don't have the answers, Fiona. It is a challenge because of the conditions our prescribers are facing. And there's always, it's so challenging to actually get in for a doctor's appointment. And then by the time you get there, you sort of like put everything on the doctor's lap and expect like a miracle to happen. And a lot of times it doesn't. It is, so I wonder whether maybe it's about raising awareness with our clients and patients through platforms like yours, where you have an amazing sort of like support strategy and collaborative partnerships, because you speak to doctors, you speak to naturopaths, you speak to like functional doctors. Perhaps this is one avenue we can do in terms of raising awareness of the pros and cons of antibiotics. In terms of your clientele, like how do they feel about having to start antibiotics?
Well, my kidney disease patients, obviously, it's generally something they want to avoid or that they're wary of. With kidney disease, it's when patients might be getting recurrent UTIs, and when they would do, natural interventions versus antibiotics. When is it heading into a kidney infection where I'm like, we need to look at antibiotics and not do natural interventions and hang around with that. So I think that's a big thing. And obviously, you're right. I'm lucky. Most of my patients are very well aware that viral infections won't respond to antibiotics and will do that at home with natural intervention versus getting antibiotics. But I guess if you're not educated on that, and when people are feeling really unwell. So I had a patient the beginning of winter season in Perth, and a young guy, and I'll call it man flu, because he was just like, I'm dying. And I'm like, it's a virus. He's like, I'm going to go. And I'm like, it's a virus. Just do these interventions because you'll be okay. And it did, it spontaneously, whether it was the disgusting stuff that I made him drink, or whether it was his immune system kicking in. But within sort of 12 hours, he was feeling much better and we managed to circumvent antibiotics. But I'm very accessible as a provider with the patients that I do look after because I work differently. And so I was able to jump on a call, field his anxieties and stop him running down to get a script, because he was quite anxious at the time because he was feeling so unwell, which is, such a viral thing. But not everybody has a healthcare provider that they can quickly get on the phone to and have that conversation with, where the pharmacists are screening that inside before handing out scripts to be an extra block to the doctor around things. It's really hard. So I guess my questions to you are, with people with chronic kidney disease, when in things like UTIs, would you go, yes, let's look at antibiotics? Do we need them with UTIs or do we not? And what are the sort of signs and symptoms, I'll let you speak to that, of when maybe it's sounding a little bit more like a kidney infection, and do we definitively need them in that? And are there antibiotics in those specific circumstances, because I know you can't speak to the broad general sort of stuff, that are maybe a little bit more kidney friendly versus ones that are definitively nephrotoxic, and maybe people with CKD should have a little flag in the back of their mind that if their doctor says go on X, that you would be like, you might have a conversation with your doctor about maybe safer alternatives.
If it's okay, Fiona, I'm going to again answer that in a roundabout way. So I promise to actually talk about how the antibiotics work.
Yes.
So they basically have got three mechanisms of action: the penicillins, the cephalosporins, the carbapenems. They have chemical structures that contain a beta-lactam ring that disrupts the cell walls or inhibit the synthesis of bacteria. That's one way. So that's disruption of like cell walls of the bacteria. The sulfonamides and trimethoprim, which we use quite a bit in prevention of UTIs, it acts on the enzymatic pathways and it inhibits folic acid synthesis. So if the bacteria hasn't got folic acid, it can DNA repair and synthesis, and they die. So that's the second sort of the second mechanism of action. The third one, where the immunoglycosides and the tetracyclines, which is your doxycycline, your minocycline, which we use for all sorts of different conditions, acne, prevention of malaria, and that class as well. Your chloramphenicol, which we mostly use for eye infections, and erythromycins, which we call macrolides. They interfere with mechanisms involved in the synthesis of bacterial proteins. Okay, so having the foundations, like this is how the antibiotics work. However, like if you look at the current theory of mitochondrial, how it actually arose, is quite fascinating and really relevant if you focus on kidney or overall vitality, that our cellular energy factories, which is our mitochondria, actually evolved from bacteria billions of years ago, right?
Yeah.
And that means some antibiotics, like the tetracyclines, the one I mentioned, that's commonly used in Australia, your doxycycline and your minocycline, can inadvertently block how our mitochondria burn fuel. So all the more reason to use these drugs judiciously and to support mitochondrial health if you do need a cause. So supporting the theory about mitochondria is that out of all our nucleuses, only the mitochondria has got its own DNA that's separate. And having that theory, plus the mechanism of action, you kind of wonder if we use those antibiotics, are the side effects that we're getting from these antibiotics, for example, with aminoglycosides, which we use only intravenously in hospital for serious infections. They've done a lot of research on it because remember when I was working in hospital pharmacy, we had to again do a drug concentration. We measured the drug concentration in the blood to make sure that we got the dosing right because everybody was different. What they found was in terms of the nutrients, like if a patient was deficient in magnesium, potassium, and zinc, it can actually influence the effectiveness and toxicity. So an example of an aminoglycoside is gentamicin, and it's well known to actually increase toxicity in the ear area, and it can be magnified in magnesium or zinc deficient states. So that's one of the elements that we kind of have to park and to think about. So how it works, the mitochondrial connection, and when we look at the results from research of long-term use of the antibiotics and its implications, quinolones, which is your ciprofloxacin, norfloxacin, so norfloxacin we use in UTIs, very useful against gram-negative and resistant pathogens, but it can also, on the flip side, cause severe neurological effects and tendon ruptures. So if you're an athlete or somebody who's going overboard with a lot of exercise, etc., having additional homeostasis on the body, plus if you've got reduced kidney function, or you use other medications that also burden and inflame the body, like corticosteroid use, you could be more predisposed to these side effects. So I think putting these elements together, this is how I would be advising prescribers and clients and patients to understand this whole jigsaw puzzle that, yes, if you have a urinary tract infection, the fear factor, what's the worst case scenario? You're going to have extreme burning sensation that doesn't get better and impacts quality of life significantly. The other thing as well, that each time we have severe inflammation, when we have a pathogen sort of invade our territory, our immune system gets hyperactivated. So that forest fire that we talk about, an acute sort of inflammation becomes a chronic inflammation. So for some of our clients who are already immunocompromised, elderly, they're at higher risk of developing that chronic inflammation that makes it worse because when the whole fire is full blown, there's so much damage that you cannot recover from it. So that's when I think you weigh the risks and the benefits of the treatment, and you go for treatment, and you do it wisely. You might do susceptibility testing to see whether there's any resistance for that particular antibiotics. We really should be using more naturopaths and nutritionists, dietitians to ensure that the host has got enough nutrients to fight off these invaders, and making sure that our immune system is fully supported with all those micronutrients we talk about, the magnesium, the potassium, the zinc, and having enough amino acids to build immune cells as well. So I think it's a bit more holistic in terms of the decision making. I would be looking at what we're trying to achieve, how do the antibiotics work, what are we up against in terms of the pathogen, and making a informed decision. So the worst case scenario for somebody is further flames of inflammation versus, I can actually I can delay this. It's going to get better in the next 3 days because my immune system is a bit more robust than the next person. I might not require it I could just hang on to this prescription. If it's not getting better within the duration that we think it should get better, then I might actually start using that as well. And that's going to help manage the risks and the benefits of treatment.
Great answer. And it's a tough one, isn't it? Because it's, like you say, really individual. And you said something earlier on that sparked my little logic brain to go into its Fiona mode. And that was, you talked about folate and how
Yes.
Bacteria use folate to regenerate their DNA. So if you were on a folate supplement when you had an infection, should you stop?
Yeah. So that's the issue, that there's emerging information that the pathogens can actually steal the nutrients that you are using to actually grow stronger themselves. So interestingly, when we use trimethoprim or sulfamethoxazole, where we use quite a lot in urinary tract infections, there have been cases of signs and symptoms of folate deficiencies. So folate's important for DNA synthesis repair. So they've had cases where they had low white blood cells using folic acid. They do suggest caution using these treatments in the elderly, in those who are malnourished or have malabsorption problems. So it can work both ways. The pathogen might be stealing your folate, and then B, you might be depleted. So it's sort of like you damn if you do and you damn if you don't.
Yeah, that's what I heard. So I'm like, wow, it's a tough one because, yeah, you're going to end up folate deficient, which you need for your own DNA repair, but you don't want to be feeding the pathogen. I find that really fascinating, of just making really good clinical decisions in some of these complex cases. And of course, we know that kidney disease is more seen as we get older, and potentially these things, we definitely know vitamin D is part of the kidney disease pathogenesis, and we know that's going to play a role in immunity. So I find all of this really fascinating about how you build up a host. And maybe, we talk about in natural medicine that we never give adaptogens, so tonic type herbs, when someone has an acute infection, because you'll tonify the pathogen. And I'm almost hearing it's the sort of same thing with nutrients that are potentially tonifying to the pathogens, such as maybe folate, that during those really acute phases that we wouldn't use anything deemed as tonifying, including our nutrients, until the immune system sort of has tipped that infection over the other end. And then when the immune system's in front, you can probably use those and it'll get shunted towards that. So I feel like maybe we should be taking that same approach that we use with herbs like astragalus, or astragalus as my US community like to call it. So yeah, it really fascinating about how we maybe don't practice the nuance when it comes to antibiotics and individualized medicine, because I feel like, and again, I'm not a prescriber of antibiotics and things like that, so I don't want to speak to something I don't know about, but I often feel like people haven't come in with that really nuanced approach, and it feels like antibiotics really do need a very nuanced, individualized plan, which again, to your point, is very hard to do in 15-minute medicine.
100%. You've hit the nail on the head. I think the reason why some people get more side effects or they have allergies to antibiotics, I think we're not actually looking at the bio-individual level of the host and their environment and what their nutrient gaps are. I think the other missing piece is understanding of the signs and symptoms of drug-nutrient interactions. So for example, if there was a folate biosynthesis issue, and the host would be deficient. So one of the things with methotrexate toxicity, one of the first signs that we actually look at is your ulcers, mouth ulcers, because if folic acid or folate is important for DNA repair and synthesis, one of your fastest growing cells would be around the mouth area. We use it so often, etc. So I normally check for like mouth ulcers, and also things like diarrhea and all those signs and symptoms that's not quite, it could even mask an infection. So it's about having a awareness as an individual yourself of where you're at baseline, and how do these antibiotics, are they worsening the diarrhea? Are they worsening the mouth ulcers? Because with mouth ulcers, it also could be other B vitamins that could contribute to it as well. So I think the responsibility is multifold. As health practitioners, we want the best for our clients. But I think clients and patients, they have responsibility as well to understand, to find trusted sources of information, to help them understand the pros and cons, and then make an informed decision. And that if they actually choose to actually use a strategy, is it working? And then B, like, what are the side effects that I can anticipate, and when is it safer to actually stop the medication or supplement?
Such great points. The other question I wanted to ask you is there's often a theory that, people take antibiotics and they'll be given a course, right? And they'll get halfway through, they start to feel better and they'll stop. And then there's the theory that you start to cause antibiotic resistance by not doing a full course. I would definitely like you to speak to that, because that is something, especially in my natural healthcare patients, that they're like, we're better because we were taking a combination of natural stuff and antibiotics, and we know antibiotics might be blowing up our microbiome, so we won't take the full course because we don't want to have all of that. But inadvertently, can they actually be causing a greater resistance because they haven't completed the full course?
I would assume so, Fiona, just because, bearing in mind the nuances in terms of what infection we're actually treating, and are we going for the guns blazing, like all or nothing, or the one that's slow and steady? If we just stop it in the all guns blazing, you're going to, again, half kill like the bacteria population. So I think it's also a numbers game. And the ones who are actually left behind, are they going to evolve? Because we know that something that doesn't make you better, and make you grow stronger, right? So that's the all or nothing sort of like part. If you're really slow and steady, and so slow and steady means that you need to do it on a certain amount of time. So for example, for a lot of general infections, like they have a lot of very potent antibiotics where you can do 1 day or 3-day courses. If you're not getting the right amount of time to actually kill the amount of bacteria, you might not even get there. So the two scenarios where one half of them killed, or B, where none of them get killed, means that both areas would have given the pathogens a window of opportunity to actually grow stronger. So that would mean that resistance would increase. And so if you decide to choose the route of going for antibiotics, it really is important to finish the course according to the time given, depending on the two scenarios, or else I would imagine that it would contribute to resistance. And the issue is, if you think that we just use something that's on the skin, like an eye drop or whatever, if you actually use a particular antibiotic and then you didn't use the full use of it, the duration, then the infection has to get better. And you're even use an oral antibiotic. But then because you've used the topical and now the bug's resistant to it, you can't use that same particular antibiotic in oral form. So that's something to again throw in the mix in terms of the complexities. And so the prescriber have to decide, what sort of infection we're trying to manage here. B, do we go for all or nothing, or do we go for slow and steady? What's the host environment, the duration and that sort of thing? Do we use a topical? And topical antiseptics are different from the antimicrobials. So for example, Dalicin or clindamycin, which we use for acne, versus sort of povidone iodine that we use for prepping for surgical infections, etc. They're quite different in terms of sensitivity to the individual, and also in terms of increasing antimicrobial resistance, less risk of causing antimicrobial resistance with the povidone iodine, the antiseptic-like preparations as well. So a couple of things to consider, I think, when it comes to if one decides to actually choose the route of antibiotic use and administration, to use it smartly, and follow the instructions, and be aware of the timelines of when do you think the infection will clear, and what sort of side effects I have to be aware of, and my baseline, am I getting worse, am I getting better? But once you start an antibiotic, you should really continue with it, especially if the prescribers made all the effort to do all the screening, as we mentioned before as well.
Such a great point. It's such a minefield out there in it. And you're right to your point, and I think it's a really good point that as patients, as individuals, we definitely need to have some self-education and some self-awareness and responsibility around that, to make sure that, one, we're following instructions, two, that we are, if it's if we know it's a viral infection, that we're not taking antibiotics because we need a panacea or we need placebo, that there are plenty of natural things that we can take of antivirals that can be really effective. You know, and it's one of those things too, I look at what, you know, my grandparents and things like that went through, and, you know, it's just our culture isn't quite as tough as it used to be. So colds and things like that, you know, and, you know, don't get me wrong, people can get very sick, but, you know, there's also that people don't like feeling discomfort. I think we've lost the ability to feel discomfort a little bit in our society. Not everybody, but so there's also, we're fighting against that. So, and we've got 15-minute medicine. So, which I don't know how any prescriber can get really good and nuanced. And then when people are really acutely sick and you want to be testing for antibiotic, which ones are more susceptible to killing the infection, you've got to then test, wait a couple of days. And so you've got all of this going on too, which is obviously not ideal if someone's got a really bad viral infection and they just want to get better and you've got to wait for testing. So I feel like just as far as medicine is set up for really acute viral infections, it's not set up in a way that really is allowing us to really win this in a really great way. I feel like that whole environment isn't set up. And into that, and I think, and you'd be able to say this, I think pharmacists are allowed to prescribe antibiotics.
So they've changed legislation in Queensland where pharmacists can actually prescribe for urinary tract infections, etc. So yeah, that is happening more and more, and I think that's an extra layer as well. So maybe that might just reduce the burden on like the other doctors.
I actually think, listening to you, and maybe it's because I'd come to see you, but I think pharmacists allowed to prescribe for things like UTIs and things like that actually, to me, makes more sense, potentially because they know these drugs probably more intimately and kept up to date with it because it's your wheelhouse, right? When you're a hammer or you seize a nail. So as a pharmacist, you know, medication is front and foremost, right? And potentially, if pharmacists aren't inundated, they've got a better chance to spend a little longer with people to get some of this information and understand the pharmacodynamics a little bit better. That I feel like that is a really good intervention or something that we can put in place that I think would be really great going forward. So I'm very supportive of that. I had heard that and I thought that's a really great idea. So, yeah.
So many of the patients I work with, especially those dealing with chronic or recurrent infections, they worry about gut health and future resilience. So when you actually like put the antibiotic script like in the pharmacy, which is, you know, we actually employ naturopaths in a lot of the major pharmacies like Terry White, Chemart, etc. Because we know that patients want holistic medicine to again, you know, strengthen and regulate their immune system when they most require it. So what are the supplements? Do we use probiotics? And we know that long courses of antibiotics, it can wall off the pathogens in biofilms rather than eradicate them. So a lot of times the antibiotics might not work or cause a resistance, so potentially making things worse if not addressed thoughtfully. So I think where the strength of pharmacy is that, you know, when I was in Vietnam, I was really surprised how when I actually went to a community pharmacy and I had a sinus infection, it wasn't me, it was my husband. And I went to, again, you know, went in trying to get one of those silver colloidal like nasal sprays, etc. And I was really surprised where they asked me whether I wanted like a supplement or what they term a complementary sort of preparation or conventional one, sort of like to use as well, like a nasal steroid or sort of like a pseudoephedrine type preparation. So I'm thinking because we kind of like have a more balanced and open mind towards like the prevention and the treatment sort of thing, that's also an ideal position. And if they come to the pharmacy, you know, we know that probiotics is hit and miss. Sometimes it works a treat and sometimes it doesn't. In my personal like you know, experience, it hasn't made too much of a difference. And I think it's because these probiotics are strain and disease specific. And it's really hard to understand what strain we you know, got rid of with the antibiotics, because you know, antibiotics are non-discriminatory. They kill everything, whether it's a friendly or enemy. And so the benefits reported with one preparation may not apply to others. We do know like if somebody has antibiotic associated diarrhea, it can be treated with some specific probiotics. For some like signs and symptoms, you might have a bit more of an idea of how to regulate the gut microflora. So I think the evidence is accumulating, and perhaps if we actually put suppose the gates for antibiotic use at the pharmacy, there might be a little, because there's so many policies and regulations, and pharmacists have always been historically known to actually be the stewardship of antimicrobial use in hospitals. So I am always thinking 100 times before I would actually recommend an antibiotic. So I can mention that the amount of time that we have a little bit longer with the client might be able to help us address like a bit more of the root cause of the condition, and perhaps why they're getting these recurrent urinary tract infections, for example. This burning sensation, is it because of they might have a genetic mutation in terms of oxalate detoxification? So a lot of times with urinary tract infection, if you have a burning sensation, and I think 30, 40 years ago, there's this dyspareunia, which is pain around the vaginal area society in the US. They found like a low oxalate diet seems to make a big difference in terms of reducing recurrent urinary tract infections and the horrible, damaging, stinging, burning sensation that comes with it. And those who actually adhered to a low oxalate diet, they had less of those signs and symptoms and less recurrent urinary tract infections. And I wonder as well, like, whether we're confusing, bacteria with sort of like some other sort of like diffuse inflammatory disorder that could be genetically based.
Such great questions, such great comments and questions there. I mean, it's interesting too, and you would know this, with the boom of what's going on in the internet at the moment with BHRT, so bioidentical hormone replacement in women.
Yes.
And now, so many women that had chronic UTIs, thinking they had chronic UTIs, go on hormone replacement, UTIs disappear.
Yes.
And it was, it was just an estrogen deficiency. I can't tell you how many times I've seen that by putting that in, and these women's lives have been turned around overnight. And I've had a couple of patients, and there's just, and we're not talking about HRT or anything like that, but a couple of patients where we've got really well educated hormone prescribers putting in a little bit of testosterone imbalance with the estrogen. And women are saying that their lives feel completely, like they feel like they are completely different people. And that's been amazing too. So I think we are starting to see a shift around some of these things, to your point of, is it really bacterial when we blame stuff on there? Or is it maybe, like you say, oxalates? Or is it hormones? And yeah, especially when we're diagnosed with something like chronic kidney disease, it's easy just to say everything's related to the kidney disease. Of course you're going to have a UTI, but we know oxalates and kidney disease often go together. And I can't tell you the same thing, hormones. A lot of our community online will be women that suddenly get CKD after menopause. And so there's a hormonal aspect. I have MS, and I can't tell you, I've just started some low dose hormone stuff, actually for my spinal cord injury, because there was a theory that it would increase acetylcholine recycling in the spinal cord, especially testosterone. And I'm in pain all the time. It's just part of what I've gotten used to. Put hormones in, all my upper body pain disappeared overnight. I was like, that was hormonal. And I'm not even menopausal. It was just obviously my levels have slowly started to decline as I'm getting into mid-40s. So there's a lot to be said about making sure that we are treating the person, not the disease cause, not the effect, not going, you've got chronic kidney disease, therefore everything's due to that, really starting to look at all of that. So I think that pharmacists, as far as being stewards into the quick hand, and it has, I know in Australia it's changed, there was a big push about not just handing out antibiotic prescriptions for viral stuff, because we started to see this huge surge in resistant bacteria. We've got that staphylococcus sort of resistant sort of stuff, and MCACs or whatever they're called, that can be like deadly. And there was a big rise in that in hospitals. My mum was working in hospitals too, and she's like, you would see it all the time, of those big golden staph infections that you just can't treat with antibiotics. They are so resistant in hospitals. So yeah, it's a really fascinating area, and one I think will get more attention. But that's some really good information and comments there that I'm going to have to sit and think about, especially about not using tonic sort of stuff, and we never use like herbs, but I'm thinking nutrients. and then really making sure to really nut in and go, is this an infection? Because when people are in that and feeling like they've been overwhelmed, people want quick fixes. And again, it's that whole about being able to sit in discomfort a little bit and actually go, are we about to treat the right thing, or are we about to cause a long-term problem for a short-term fix that you're going to have to then manage for a long time? So fascinating. Therese, thank you. Is there anything else you want to add about antibiotics, or anything else that we haven't covered that you think is really important to add to this conversation?
Okay, so the last thing is about interactions. Like if somebody chooses to actually go for antibiotics, you want to make sure that some of the antibiotics, like the quinolones, like the ciprofloxacin that we use for urinary tract infections, they can actually bind to aluminium, calcium, anything that you find in N-acids, magnesium, or bismuth salts, iron, and impair absorption, and should not be given in patients taking things like doxycycline for ciprofloxacin. So I think milk and drinking it with doxycycline that sort of myth has been taken off, because you can take doxycycline with food or milk because it can reduce absorption, but it's not significant. And so obviously, somebody can try going on an empty tummy, but then if it irritates the gut, then you might need to have a bit of food or milk to actually just buffer it. There's lots of precautions with antibiotics, and because we share, the whole mitochondrial aspect as well, I would be, having a think in terms of with tetracycline. We don't often recommend it in kids under 8 years because of the mineralization of the teeth and how it can really cause hypoplasia of the animal and discoloration, because tetracyclines like doxycycline, minocycline, it can accumulate in the growing skeleton. So I think, be very, very aware of what you're putting in your body in terms of the risks and the benefits. A lot of these ones are antibiotics. They make you more hypersensitive to light. So be careful with going out in the Australian sun, or if you're in a summer place as well, you might want to again put in a big hat and cover yourself up. So I think be aware of the risks involved with the antibiotics as well.
And are there any antibiotics that just are a big no-no in kidney disease that you go, they're definitely nephrotoxic, or that it's more an individual thing versus that?
We talk about how the dose makes the poison and the therapy. I think it would be dismissive of myself to say only use it for this particular condition or not the other. I think it's, again, multifactorial. We need to actually treat the person as an individual and then help them make an informed decision based on their bio-individual differences. There's no cookie cutter size approach. Any of these antibiotics can be toxic when there's renal impairment, because a lot of times the side effects are dose dependent. And also, if it's not cleared up, if we share it like the mitochondrial story as well, it can cause, whether it causes DNA issues in our cells. That's a different question mark to consider. I'll leave that in a very gray area, because we're just learning so much about that aspect.
Thank you. So good. I really appreciate your commentary on this, because it is a question that we get asked a lot, and it is a lot more complicated than I thought it was, about just avoid these ones and then do these ones. It's obviously not that at all. So I think for anyone listening, what I took away from that is making sure that maybe you book a longer consult with your provider if you've got kidney disease and you're worried, to make sure that you can have that information and have a slightly longer conversation around it. If you feel like it's an acute sort of infection, maybe writing it out. Again, with kidney disease and you're getting recurrent infections, it might be good to go in for testing to actually make sure that you're using a correct strain that is going to kill off whatever bacteria that you have. And then maybe working with a good healthcare provider that can work alongside the pharmacist and your prescriber to make sure that the host, as far as you are in tip-top shape, to make sure that your immune system is recovered, you're looking after your mitochondrial health, very important in chronic kidney disease, and that you're looking after your microbiome and all those sort of things, and ruling out things like oxalates. We do know that definitely causes UTIs, and of course hormones in perimenopausal, if we're talking specifically UTIs. So I appreciate all of that. Therese, if people want to find you, we've obviously got your podcast for people to listen to, which I'll put that in the show notes before. That's the Enlightened Pharmacist podcast. Really great guests that she's had on there. So definitely go and listen to that. If you're a healthcare provider in Australia, I highly recommend reaching out to Therese. I'll put her information in there. You can find her on LinkedIn. I know you're writing lots of good posts, and your socials are very good as well on Instagram, so I'll make sure I put everything there below. But if you're a healthcare provider and you want to have someone on your team, then I highly recommend Therese as well, because she's just amazing and genuinely cares about the patients. But over and above, like, the reports I get are amazing. So, like I say, best person I've added into my healthcare team in 2025. Again, not sure, you're stuck with me now because I'm not going forward without you. So yeah. So again, thank you. Anything else you want to add before we wrap it up?
I'm loving working in this collaborative space. It just spreads the love, and I think the patient wins in the end. So definitely, like, want again keep this momentum going.
Ditto. I love it. And you're right. It's all about making the patients win. That is the most important part. So I couldn't agree more. So make sure you hit subscribe and like. That way you'll get notified anytime we put up new content. If there are any particular drugs that you would like to Therese talk about when it comes to chronic kidney disease, please put that in the comments below. We've covered lithium, we've covered the triple whammy effect, and now antibiotics. But if you've got drugs that you want to know more about and their effects, and if they're nephrotoxic or on the kidneys, make sure you pop that in the comments below, and we will definitely get the beautiful Therese back on to talk about that. If you want to know more about what we do, head to www.kidneycoach.com and you can find out more about us there. And we're the same, we're on socials under the same banners, handles, whatever that word is, and we are putting out new content every day. Again, thank you for being part of our community. We hope you found this useful. We look forward to seeing you next time. Therese, thank you again, and I will talk to you all soon. Bye.